Welcome everyone. We're excited. This is our initiative, which is in spirit, and the groups we run are End of Life Matters. We have an amazing team here, and thank you for being here. So we have Henry Verso-Weiss, who...
Right. So I'm an end-of-life doula and a social worker, former hospice social worker, and I created the first end-of-life doula program in the United States back in 2003. And I've created programs in a number of different kinds of facilities, and I also teach this publicly, and I created a nonprofit organization in 2015 to really foster the growth and development of the end-of-life doula approach to caring for people as they're dying.
And your book?
Okay, yes, my book. I did have a book published in 2017, which is called Caring for the Dying, Doula Approach to a Meaningful Death. And that book, I think, is just about the only book out there that is clearly focused on the work of what doulas do. Our stories showing you what our work is like, as well as it gives the whole kind of scope of what the program is all about.
I've taken Henry's class twice. It's invaluable whether you want to do it professionally or personally, and Henry hopes to be teaching it at the Bronx Center in January, so we hope you join us. And we have Manasham, who is the leader, really, spiritual leader of our program.
I also took Henry's end-of-life training, and we're really looking forward to getting that to happen here. So just keep you all posted about that. It's really incredible the work he does, and it's amazing to have him as part of this initiative here. My name is Ganesham. I lived here in the Buckley Center as a monk for 11 years, and then transitioned out and began working in the world. I found out about chaplaincy, spiritual care, and hospitals. So I'm working at New York Presbyterian Hospital as a Hindu chaplain. I also did chaplaincy at New York University. So chaplaincy just means spiritual care, end-of-life care. So that's kind of the work that we do. And yeah, grateful to be part of this initiative. And
Manasham is amazing. He teaches from the Gita and has so much to teach us. I've learned so much from him. And our recent member, and we're so blessed and to have Dr. Joe Sacco on our team. And he has a lot of credentials, so take it away.
Thank you. So first of all, I just want to say how grateful I am to have been invited to talk about this. My name is Joe Sacco. I'm a regular doctor, and I spent 20 years in family medicine. I spent most of my career in the Bronx, took care of a lot of very sick people, both in the hospital and in the clinic, but sort of diabetes and high blood pressure and HIV and heart disease and sort of all of that. I did that for 20 years. I was at Bronx Lebanon Hospital, if any of you know that hospital, for almost 25 years. And in 2004, I started a palliative care program, and I haven't looked back since then. So, should we get started?
Yes.
I'm looking to our leader. Barbara, I'm just going to go ahead and start, right?
Yes, we're ready to start, absolutely, and thank you again.
It's a privilege. Actually, it was interesting because a couple of moments ago I was asked would I be sort of talking about the emergency room. So did you have a bad experience with the emergency room?
No.
Okay. But you were curious about that. Okay. You know what, I think actually before I even start, I'd just be interested if other folks could sort of say what your interest is in this, or even sort of who you are, or what your interest is, just to kind of go around the room, if that's cool.
Sure. Hi, everyone. I'm Jaya Bao. I am a physician researcher and also a family nurse practitioner. And I am a regular here at the Buckley Center. I'm really interested in palliative care. So I'm very happy to be here with all of you. Thank you.
I'm Julie Gaines, and I am interested in Michelle.
She's my girlfriend. She's here to support me. I'll take it.
And what he has to say.
I'm Uti Patel. I'm a journalist and interested in palliative care for myself and for others.
I am Maida Sudhakar. I am a social worker
kind of social work do you do?
I work, I do care management with the children.
Okay.
Hi, I'm Margaret Peter, and I'm listening to the class at the Open Circuit.
I'm sorry, I'm not hearing.
At the Open Center.
Okay.
The class of Art of Dying, and that's why I'm here to attend the we're going to be here, so I'm calling everyone.
Thanks for coming. I know we met, but
Okay, I'm sorry. My name is Deborah, and Barbara invited me, and we're curious to hear what it is you have to educate us on.
Okay. Thank you.
My name is Eve. I have a background as an RN, and I've dealt with hospice and volunteer and worked for hospice before, so I'm always looking for new tips and information.
And what hospice organization have you worked with?
Jansen.
Jensen.
Barbara, and I think that information and knowledge and options are, imperative, and that we have to know this for ourselves and our loved ones. And I hear too many stories that are frankly frightening, and I think we have to take responsibility into our hands for ourselves and our loved ones.
And in the back?
I'm Seth Kirkin, and I'm an administrator of the assisted living facility in California.
I'm Terry, and I spent a few months with my father as he was dying and through his death process. And I found it really interesting, and I just want to learn more to, support my mom, whatever her time is, as well as learning more.
I hope it went okay with your dad.
Oh, it was good as it could have been.
Hi, I'm Kuhei Marashi Kurgan. I'm Seth's wife, and I took the Ends of Life doula training course like 6 years ago at the Open Center, and my mother-in-law asked me to come with Seth. But I love being at the Bronx Center. I've been studying the Bronx Center for like 8 years now. And my glasses are prescription, so if I put them on, it's only because I can't see far away.
Well, thanks for coming and thanks for supporting your husband.
Thanks.
And also obeying your mother-in-law. Yes, here.
Okay, my name is Ann Stetson, and Barbara and Andrea invited me, and I'm just curious about the topic, and I'm also curious to say about
Andrea?
Well, Barbara was telling me that you were going to talk about how to negotiate the medical world. My practice is holistic health.
Okay. And you haven't introduced yourself.
My name is Virginia, and I had several people who were close to me die a couple of years ago, and then I became very interested in death and the dying process. I've taken the end-of-life training in seminary, and I now work in hospice and individual.
Which hospice?
I work with ENS in London.
ENS. Okay, great. So thank you all for being here. And please, this is definitely interactive, so if you disagree with me, just jump up and start yelling, or if you have questions or whatever, okay? So actually, I think the question about are you going to talk about the ER is a really good introduction, because the ER is a point of entry into a gigantic bureaucracy, which is modern American medicine. So when I answered the question by saying I'll talk about the ER in the context of the overall talk, what I'm really talking about is how, as a seriously ill person, how does a seriously ill person understand how medicine really works? And with that understanding, then how to sort of move forward in terms of accessing the care that you actually want. Because the system is oriented, and when I say the system, I'm talking about the system of American medicine. The system is oriented to provide a certain kind of care, and that's not always appropriate for everybody. So, but it may be appropriate for some people, but the idea here is to understand what some of the forces are that sort of funnel you into the system and how to take control of that process. Now, people have talked about the end of life. I want you to know that I'm not talking necessarily solely about the end of life. I'm talking about serious illness. Okay? Now, serious illness may progress and get worse and result in the end of life. But this is a much broader subject. If you think, remember Venn diagrams from high school? The big circle and then there'd be the little circle inside. So palliative care is a specialty that's you know, I'm board certified in palliative care. It's a specialty that is limited to the care of seriously ill people. Wholly contained within the specialty of palliative care is hospice care and the care of people who are dying. Now, I don't know if everybody in the room knows, but the only requirement that Uncle Sam imposes in order for somebody to access hospice services is that a doctor certify that that person will die within 6 months. That's the only requirement that hospice requires. Once a doctor certifies that, Medicare will pay for that service. Okay? But palliative care is much broader, and we're going to get into that. Yes?
What if they're not at the age that they're eligible for Medicare?
So that's a really good question. Most other third-party, so the question was, if you didn't hear it, is what if you're not eligible for Medicare? Almost every third-party insurer in this country pays for hospice care. And like Uncle Sam, they impose requirements on hospice organizations in terms of the kind of services that they provide.
Also, does it, it's for 6 months, but what if you live beyond 6 months and you're
So generally what happens is that if somebody lives beyond that 6-month prognosis, a doc comes in and recertifies, right? And oftentimes we'll recertify up to a year or a year and a half. And a lot of times sort of in hospice with the nurses and the social workers and the doctors, we're all kind of, it's like with a wink and a nudge. We're kind of certifying somebody as they're going to die within 6 months. But oftentimes it's somebody who's seriously ill and we want to provide the care. One of the ironies of hospice is that people often get better in hospice because the care is often terrific. And then they get better enough that they no longer qualify for hospice, so we have to discharge them because now we can't certify that prognosis. And so one of the other reasons that I had sort of talked to Barbara about doing this tonight is because I was here weeks ago, right? And everybody was talking about, well, you were talking about in particular, but talking about sort of the spiritual and emotional and psychic sort of aspects of the dying process and how to sort of, in a sense, take control of that or understand it or in a way sort of transform that process, as you have said, Barbara, from dying to living until you die, right? I've heard you say that before. And what struck me was, you know, these poor folks don't know what they're in for when they go to the hospital. And that sort of prompted me to sort of want to do this talk, because I think in order to even get to that point of getting your head around this reality and living fully, you have to be able to make choices just to get there. And I don't mean to sort of talk about the medical system as sort of evil, but there are forces within the system that can direct you in a way that you might not want to go. And so the idea here is to choose the care you want. Okay, any questions? Okay. So remember, it's serious illness as well as the end of life. Okay, so read this. If I sent everybody's blood pressure up 10 or 15 points, everybody should be feeling a little anxious, right? When I lecture medical students and residents and other docs about palliative care, I tell them, imagine you're home one night, it's 9 o'clock, you've had a long day, it's been really trying, and you get a call from your cousin who doesn't know medicine from anything. Your cousin is a IT specialist. And your cousin is on the phone and she's really stressed and anxious. She says, I don't know what to do. It turns out that mom went to the doctor, I think it was last week, she went and she didn't tell me about it. And there was something about her mammogram, and I don't know what happened, but she told me today that she went back and the biopsy showed that she has breast cancer, and I don't know what to do. And I always tell people, why did that person call me? Why did that person call you? They called you because all of a sudden it's like this. It's like, oh, what's the word I can use while I'm on camera? Oh darn, this is bad. Okay? Now all of a sudden I'm in this position where I'm going to have to deal with this huge system of American medicine, and I don't even know where to start. Okay? So the person calls you, number one, because you have a set of skills that she doesn't have. You know this system. And number two, she called you because she knows that you have her back. She called you out of love. I'm going to call someone in my family who I know and trust, who I know will advocate for me. And I'm going to talk a little bit more about how palliative care sort of meets some of those requirements. Remember, I have an hour and a half, so ask questions. So I want to make sure that we do not throw the baby out with the bathwater when we're talking about big, evil hospitals. Okay? Hospitals and medical practices and cardiologists and neurologists and pulmonologists many of them are just lovely people. I became a doctor because I wanted to help people. And people want to do a good job. They want to help you to get better. Okay? That's the motivation for the vast majority of you. I had a friend once who went into anesthesia, and I said to him, "Why are you going into anesthesia?" It was back when we finished medical school, and he looked at me and said, "Because I want to make a lot of money." That was the only time I ever heard that, actually, from a doctor that early in their course. $3.3 trillion in, what's that, 2016? $10,348 per man, woman, and child in this country. I'm like, I'll take a check. Just give me my 10 grand in a check. I'll then take my chances. Almost 20% of our entire production of goods and services is counted for by this. So, the point being that this is a gigantic business. It's a gigantic business, and an understanding of how this business works is going to put you way ahead of the game. Should you, or someone that you love, or a friend, be confronting serious illness? And when I say serious illness, remember, I'm also talking about illness that can be cured. Remember I said I'm a regular doctor? My favorite thing is curing people. People always say, what does the patient want when they come into the room with you? Right? And what I always say is they want not to have met me to start with. Right? They want not to have to come to the doctor. They want to go about their lives. Okay, so my favorite thing is to cure people. And believe it or not, in the context of hospice and palliative care, I still do that. Okay, we think of hospice as the end of the road for people, but we still do that. And I'll explain that a bit. Just say what you want.
Insurance.
Insurance.
Government funding.
Government funding. Private.
Private grants.
Private what?
Grants.
Grants. So I have to say that, I do this talk with medical students, and I do it with residents, and I do it with attending doctors, and nobody knows how hospitals are paid. You guys are generally right? But your answer is like saying, you buy something in the store with money. I'm sorry. But here we have obviously a room full of very intelligent folk who have a lot of life experience, but really no idea of what it is what's going to pay for you if you have to go to the hospital. By the way, before I go on with this, I just want to ask people to sort of throw out words that you think of when you hear the words palliative care. Just throw out words. Anything. Don't be shy. You can't. Morphine, my favorite drug. I use so much morphine. I saw a patient at home the other day who had a lot of shortness of breath, and he said, "Thank God for morphine." What else? Specialized care. Who said that? Good. Good. I like that. I haven't heard that often. Anybody else? Ally. Oh, another good one. Thank you. Other ones? Caring.
Pain relief.
Pain relief. Good. The Centers for Medicare and Medicaid Services, which for some reason is called CMS instead of CMMS, will tell you. You can Google this. And you can't even read this, and nor can I. But the essence of what it says is that hospitals are paid prospectively. Okay? So that means that, you know the whole thing about, oh, an aspirin costs $200? That's actually not true. Okay? Hospitals bill $200 for an aspirin, but they don't get paid $200 for an aspirin. Hospitals get paid prospectively, and I'll explain more about what that means. These prospective payments are based on an estimation of how much it will cost the hospital to take care of a patient with a given diagnosis. I promise you I won't waste your time. And then there's various frills and outlier payments. So for example, there's something called disproportionate share payment, which goes to hospitals that take care of a large percentage of uninsured people. Hospitals that have residency training programs get extra payments for the residents, for training the residents. And also, if a patient is particularly costly for the hospital, there's outlier payments for that. Okay. So, and all this stuff is available on the web, by the way. Okay, so here's a primer. Is it primer or primer? I could never get straight. Is the word primer? Primer? Whatever.
What does CMS stand for?
It stands for Centers for Medicaid and Medicare Services. Okay, so Medicare, right, is the insurance program for people who are 65 and older, or for people who are disabled and qualify for what's called Medicare disability. Right? So Medicare, it's funny if you think about the government in terms of its role in healthcare, the government actually takes care of the sickest people in the country. So it takes care of elderly people and disabled people, and then Medicaid pays for the custodial care of people in nursing homes, and it pays for health care for the poor. Okay? So those are really the highest cost populations in the country. Third-party insurers like Aetna and the rest of it take care of just regular folk who generally access that through their employment. So they're working. So by definition, that's a healthier population. Okay. So, a diagnosis, and I will be explaining this with examples. A diagnosis is given an estimation of the resource expenditure that is required by the hospital to care for the patient. So it's everything. It's antibiotics, lab tests, housekeeping, dietary, x-ray, etc., nursing care. All of that is taken into account in terms of assessing what the cost is to the hospital of caring for a given patient. So the average patient with the average diagnosis who consumes the average amount of resources has this number assigned to them called relative weight, and that number is 1. It's the average. And then what they do, and Medicare, if by the way you think government's out there kind of doing nothing, Medicare has assigned what's called a relative weight to every single diagnosis in the known universe and a couple of the alternate universes. Okay? I mean, they have thousands and thousands and thousands and thousands of what are called relative weights assigned to diagnoses. Then, CMS has attributed to every single healthcare institution, every single hospital in this country, has what's called the base rate. Okay, and that takes into account their local costs. So do they have a mortgage on the property? Is there a balloon payment coming up? What are the average salaries for nurses in a given area? Okay, what are laboratory costs? Okay? How big is the hospital? How many beds does it have? Does it have residents? Does it have fellows? Does it have... Ooh, that's bad. That was a team effort. Thank you. We're in business again. Thank you, everybody. So, again, so the base rate is Medicare's estimation, and I promise not to continue boring you with this, but it's Medicare's estimation of what does it cost the hospital to take care of the average patient. Okay. So think about, you work at Presbyterian, right? So Presbyterian has 1,200 beds, about 10 ICUs, about 7 or 8 residency training programs, and about 10 fellowships on a giant piece of property in Upper Manhattan. So their costs are going to be higher. So they may have a base rate of, I just made this number up, about $15,000, probably about accurate. I used to go to Alaska every summer and work in the Bartlett Regional Hospital emergency room. Bartlett Regional Hospital had a free cappuccino machine in the lobby. There wasn't a resident doctor in sight. It was all run by nurses. And the private docs would come around and write notes. Had 50 beds. So their base rate would be lower just because their costs overall.
I have a question.
Yes.
Do pharmaceutical companies pander to hospitals with higher ROI?
So pharmaceutical companies will market to the docs in a hospital like Presbyterian as opposed to a hospital like Bartlett, because they know that, especially in referral centers, because they know that the more complicated patients who may have more advanced disease, who are eligible for newer and more expensive medications, are going to be cared for in those facilities. So somebody who reports to Bartlett Regional Hospital with a malignancy, right, probably is not going to get offered a drug that costs $12,000 a month. But if they get referred down to Seattle, to an academic medical center in Seattle, that hospital is probably going to offer that, and that's where the drug reps will be. Okay, so you could read this yourself, but let's say a healthy 35-year-old woman gets some pain with urination, goes to her doc, gets diagnosed with a urinary tract infection, right? Gets a prescription for an oral antibiotic, and then a couple days later reports to the emergency room, now having fever, having flank pain, having vomiting. Okay? So this is the ER. Okay? So this is this person's point of entry to the system. She gets diagnosed with a kidney infection. She gets a couple of days of IV antibiotics and IV fluid and feels a whole lot better and goes home. Remember, I wasn't going to throw the baby out with the bathwater. She got better. She feels better. She's going to go home, go back to work, etc. Now let's imagine that this is that average diagnosis that I described to you. It has a weight of 1. And the base rate for the hospital is $13,500. That's what the hospital gets paid. Okay? So this is how, when you say insurance pays, this is how insurance pays. And Medicare leads the pack. So what Medicare does is followed by everybody. Aetna does it this way. Everybody. Anthem does it this way. Yes?
So does the insurance companies determine what the base rate is for a given hospital? Or does
Medicare does.
Medicare?
CMS does.
Okay, they determine the base rate for every hospital that.
So CMS is really the only organization that has the resources. I've actually been down to CMS. I've been down to their headquarters in Baltimore. It's like a college campus, right? And they have like the blast barriers and the mirrors that go under your car. Like, who's going to blow up CMS? Nobody even knows it exists. But it's enormous, and there's not a single patient there. But I do have to say that the people that I met at CMS were actually really lovely, dedicated, smart, informed people who wanted to do their jobs right. All right, so let's take another example. Here's a male patient with a couple of risks for heart disease. Gets chest pain, goes back to the ER. Gets diagnosed as having a heart attack. They bring him into the CCU. They do a stent. They give him some meds. His chest pain gets better. And he goes home 5 days later feeling a whole lot better. They saved his life. Okay? Now maybe the estimation of resource expenditure for this guy is it's actually, the hospital has to spend 2.7 times the resources that it spent for the woman with a urinary infection. Okay? Why? Well, he's in the CCU, so the nursing ratio in the CCU is different from the nursing ratio on a regular floor. Okay? So there's one nurse for 2 patients instead of 1 nurse for 6 patients. And he got more in the way of lab tests, more in the way of x-rays, more in the way of pharmaceuticals. Okay? So it's a higher expenditure. Medicare takes that into account. And so now the hospital gets the base rate times the relative weight. So that's 2.7 times 13.5. So that's what they get paid. That's how it works.
So when you get billed for Medicare, your insurance company is itemizing all the things, is it actually based on this or actually?
They're itemizing it, Medicare is throwing that in the trash and paying them the perspective.
So what we get in the mail showing what was costed out is not real, that's really what we
Right.
get.
This is how it
It's
works.
a bunch of administrative waste going on too.
Right. Now remember that Medicare pays 80%. So if you have Medicare and you don't have a Medicare supplement, you're going to get billed for the other 20%. Okay, you guys following this? Are you wondering why you came to the class tonight?
Well, wondering what we do about it.
But we haven't gotten to the bad part. Okay, let's play You're a hospital CFO. You're the chief financial officer. What do you want?
That's full.
What?
That's full.
The bed's full with what? What kind of patients? Sick patients, why? Because the RW is higher, exactly. The sicker the patient, the higher the RW, the more money you're going to make. Okay? And I got to tell you, I've known some hospital CFOs, and of course I'm going to say they're lovely people. The hospital CFO at Bronx Lebanon, where I worked, his dad was in the CCU, having a heart attack. He's a good guy. But when I said to him once, what's your job? He said, my job is to make sure that the sickest possible patients get admitted to the hospital. He didn't miss a beat.
So if that's the case, why did they throw you out of the hospital so fast?
That is such a well-timed question. Thank you. What's the next thing? I said, what 2 primary objectives? What's the second objective? If you're getting a prospective payment, what's the worst thing that could happen? You stay there too long. Why?
Because it's not based on the number of days.
No, but why is it bad if you stay there too long for the CFO? Because every single second that you stay is costing money. It's a prospective payment. So if you're going to get $50,000 for a patient who's in the hospital, but they consume $75,000 in resources, you lose. And the way that this is, the surrogate for that is length of stay. So there you go. That's why they're always pushing you to get the hell out.
So they get one payment on prospective basis.
Unless it's like egregiously an outlier, and there are outlier payments for that. So there's 2 things. You want the highest RW, and you want the lowest length of stay. Now, are you getting a sense of what is happening to you as you get admitted to the hospital? Are you getting a sense of what some of the undercurrents are?
But you're also pushed more into ambulatory care.
That's true. And I don't want to talk about that right now, but we can. Okay, so you guys got it. And I tell you, I used to go to meetings, administrative meetings, people were saying, we got to get the patients out. Out, 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 out. Out. One thing that we left out is that if you take a patient out of a bed, if you take a patient with a high-paying diagnosis out of the bed, what can you then do immediately next? Put the next high-paying patient into the bed. Okay? So if you're working in a hospital and the emergency room is backed up with people who are waiting to go to the ICU, I promise you that the docs who are working in the ICU are ripping their hair out trying to get patients out of beds. They're trying to get them out of the ICU. Get them out, out. We need them out. Send them out to the floors. We got people waiting in the ER. And every day, senior administration is calling and saying, what's going on? What's going on? We need beds. We need beds. Open them up. Get them open.
So then they discharge people who were very sick, and some of them end up back in the hospital.
So Medicare got wise to this, and Medicare did something where they said, if a patient is admitted for the same diagnosis within 30 days of discharge, you don't get another payment. Okay? So the avoidance of 30-day readmission is a place where people get executed. If the 30-day readmission rate goes up, heads roll. Okay, so what hospital, the first thing that a hospital CEO does every single morning is look at a nice, crisp, freshly printed out piece of paper on his or her desk that has two things written on it. It has the case mix intensity and it has the average length of stay. The case mix intensity is all the relative weights of all the patients in the hospital that morning divided by the total number of beds. Okay? So that gives you an average of the sickness of everybody in the hospital. You want that higher, 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 higher. Right? And the other thing is average length of stay, which is the number of bed days of occupancy of all the patients in the hospital divided by the number of beds. So it gives you the average that each patient has been in the hospital. If the case mix intensity has gone down and the average length of stay has gone up, what does the CEO do next? Picks up the phone and calls the CFO and starts screaming. What's going on? The CFO picks up the phone and calls the chair of surgery and the chair of medicine and starts screaming. The chair of medicine calls up the director of the ICU and says, what are you doing? Open up the beds, get the patients out. And if you think I'm exaggerating, you're wrong.
Does this apply to like a VA hospital, like a family?
It applies less to a VA hospital because they have a whole other mechanism of payment. That's a really good question. It doesn't apply to a VA payment in a hospital because they do it differently. VA hospitals apparently have their own issues. I worked at the Bronx VA for a while, and guess what people were like there? They were lovely, dedicated people. When I started at Bronx Lebanon in 1993, the average length of stay was 8 days. When I left in 2016, it was 3.9.
I was just gonna say, in the olden days, the hospital was keeping so long, you had to fight to get out.
That's right.
And they were trying to keep the bed filled.
Times have changed. Okay? So you get the sense of where I'm going with all of
Did
this?
that change because the structure of the reimbursement changed?
Yes. What happened was Medicare started paying hospitals prospectively everything. They used to do fee-for-service. They don't do it. They pay doctors fee-for-service. It's another issue. So on the side of relative weight, DRG 003. Just if you ever meet a hospital CFO, just kind of go DRG 003 and see what his or her face looks like. I'm sorry, this is all really small, but DRG 003 is it's one of two things. Okay, it is ECMO, ECMO. Maybe I didn't focus this. Maybe that's the problem. So ECMO stands for extracorporeal membrane oxygenation. The other thing that qualifies for this DRG, so by the way, I didn't tell you, the DRG is sort of what the relative weight is based on. It's a sort of a diagnostic cluster. Okay? The other thing is a tracheostomy. Does everybody know what a tracheostomy is? I'm going to show you. No, I won't gross you out, I promise. I'll show you. And then a second major operative procedure. So, let me hear some relative weights.
Well, what was the first one?
I made it up. Oh, the first one was ECMO, which I'll tell you what it is. It's bypass. It's cardiac bypass. But just, guys, don't go overboard with this, but what do you think the relative weight is? I'm not telling you. You just guess.
The ECMO would be higher.
So how high? I said the lady with the UTI was 1. I made that up. The older guy with heart attack was 2.7. What did you say? 3. I'm going to tell you. Here's ECMO. ECMO is your blood comes out of your venous side, which is your right atrium. It gets pumped to an oxygenator. It changes color, and it goes back into your arterial side, into your left atrium. This is a procedure. When you hear people say, I had open heart surgery, if it's genuinely open heart surgery, like when you hear that, you don't really think about it, right? But think about what that means. So your chest got open, your sternum got opened up, your lungs got exposed, your heart got exposed. They went through the multiple membranes that cover your heart. And then they opened up your heart, for example, to put in a valve. So you had a floppy valve, okay? And that floppy valve was killing you. Okay? It caused you to have heart failure. You couldn't walk across the room without getting desperately short of breath. You were going to die, and you went to get a heart valve. Does anybody in this room know anybody, not know somebody who's had heart valve replacement? You do? I mean, I'm saying, does anybody not know someone who's had a heart valve replacement? You don't know anybody who's had a heart valve replacement? I bet you do, you just don't know it. So think about this. If they're going to open up your heart and replace your mitral valve, which is in your left ventricle, which is the main place of that everything happens, where blood gets pumped, what happens to your heart while they're operating on it? Your heart is stopped.
It's stopped.
You can't operate on a beating heart. I mean, you can't do it. I have been to the operating room.
Is that on a TAVR also?
What's that? TAVR is different. That's done with a catheter. Okay, transaortic venous replacement. That's done with a catheter. But it can't be done for everybody. Okay, so I have scrubbed on cases of open heart surgery with valve replacement. I have to tell you, it's incredible. It goes on forever. It's like 5 hours. You're like, oh my God, you know. It's, you know what it's like? It's like, and it's very methodical. It's like every single step has been vetted over years and years and years and years and years. And the cardiothoracic surgeons, they go to medical school, they do a residency in surgery, and then they do like 7 years of a cardiothoracic surgery fellowship. It takes forever, right? But it's literally, it's like an IKEA cabinet with 6,000 pieces. Put this into here. Put this into here. 5 hours later, put this into here. It's a step-by-step process. But I have to tell you that when the chest cavity is opened and you see a beating heart right in front of your eyeballs and stuff, wow. And then they spend 2 hours doing this. And then they flip a switch, and your blood goes out of your body into a gizmo. It comes out blue, goes through the gizmo, gets red, goes back into your body. So now you have a device that is breathing for you and pumping your blood. I mean, this is pretty extraordinary stuff. And then what they do, and I was like freaked out. I mean, I've been a doctor for a long time. What they do is they go in with a pair of the little defibrillator paddles, and they stop the heart. They go, this heart just stops. It's like, what? You just killed the guy. And then they operate, and they open the heart up, put the new valve in, sew it back closed again, undo all of the tubes, right? And then they do the defibrillator paddles, and they shock the heart, and the heart just starts beating. It is incredible. This saves lives. This is what I'm telling you about not throwing the baby out with the bath. This saves thousands and thousands and thousands of lives. And these are people who go home and they feel great. Now they can breathe. I'm sorry, I was going to warn you, there's a little bit of blood in this. But here's a guy on ECMO, and you can see his venous blood is kind of purple and his arterial blood is kind of red. So these folk are going to do something big on this guy. Okay, but that patient is probably going to come out of the operating room healthier and happier as a result of this. There's a baby on ECMO. Man, look at all those contraptions. I have a friend who I went to college with. He's a nationally known pediatric cardiologist in Florida. And this is what she does. she does heart transplants on babies. So everybody in the room who's ever had a baby, think about it. Your kid is going to die. And with this technology and a donor, unfortunately, your child gets to grow up. She just went to the wedding of a guy who was 30 who she transplanted when he was 4. I mean, that's amazing. That's incredible. All right, so the other two things is the tracheostomy and the second surgical procedure, which I'll explain to you. I sort of was like kind of toying with showing you guys those pictures, but then I decided not. So the tracheostomy is simply an incision gets made here, right? And then a tube goes in to your windpipe. Okay? So this is the alternative. I don't know if you guys know what intubation is, but intubation is like in an emergency, tube goes into your mouth, goes down into your windpipe, gets connected to a ventilator, you get sedated. Saves your life if you can't breathe. Okay? But eventually you can't leave them in for very long. You can't leave the oral tube in because the trachea will get scarred. So you have to do this. If someone's going to be on a ventilator with ventilator support to breathe for more than 5 days, you have to do this, or their trachea will get scarred, which is bad news. And typically the second procedure is called a gastrostomy, which is just a tube that goes into your stomach. And the purpose of that is to feed you, if you can. So imagine that you get busted up in a car accident, and you're in the surgical intensive care unit for a couple of weeks. You've been orally intubated. They have to do a tracheostomy on you so that you won't get scarring, and they have to feed you, right? But you get treated, and you get better, and you get off the machines, and you go into a regular hospital room, and you start to be able to eat, and they pull all this stuff out. I bet you everybody in this room has seen somebody who has that scar. Scar from the tracheostomy. So I'm not going to go overboard with how this benefits people, but obviously, clearly this benefits people. Okay, ungross pictures of real people. Here's the tracheostomy. There's the feet. I hope you thought they were ungross. I was like, they look pretty good to me. Okay. Where we have 5, 8, somebody said 8 for the relative weight. Drum roll. Your payment, you're the hospital CFO. Your payment, CFO?
Wow.
That is $238,368.50.
How many days would that be?
The average is 32 days
Oh, that's a lot.
in the hospital. The average. The Medicare average.
And that's for both the tracheostomy?
It's either for ECMO or it's for a tracheostomy and a feeding tube. Bada bing. Bada boom. Yes.
So once you get the tracheostomy, though, it pretty much means that you have to go into like a place where they're going to be taking care of you.
Yes. Well, it depends on whether or not you're going to get better and maybe breathe on your own eventually. But I'm going to talk about that shortly. It's a well-timed question.
So doctors, nurses, everybody gets paid.
Yes. Well, no, the doctors get paid separately because they get to bill separately for their encounters with the
It's
patient.
just the hospital.
But the hospital gets paid, and the hospital takes care of all their costs from that. So the mortgage, the housekeeping, dietary, laboratory, nursing costs, all of that come out of the hospital's payment. Doctors bill separately. So this is called Medicare Part A, and doctors bill something called Medicare Part B, which is fee for service just for seeing a patient. So I used to see like 20, 25 patients in a day, and in each one of those visits we were worth about $200. So I would generate $5,000 for the company overall. Okay. I don't mean to be too sarcastic about the death with dignity thing. We're going to get more into this. But let's take away the tracheostomy and the operating room procedure and let you die with dignity. Remember, you're still the CFO. You're not.
But for your health process.
Your health process. My job, my pension. I need those tracheostomies. I need those. Okay. what would you guys say if I was to tell you that shortly after I began the palliative care program at Bronx Lebanon, I got a call from the then chief operating officer, who's no longer there, who said to me on the phone, would you think I was lying if I said to you, he said to me on the phone, can I swear on camera?
Yes.
This is what he said to me. He said to me, Sacco, what the fuck have you done to our tracheostomies? I didn't know any of this. I had to go learn it. I was like, what have I done to your whats? He said, you're bringing people out of the ICU before they get tracheostomies and we're losing money. So what are you talking about? So he brought me to his office. We yelled at each other. He told me about his son, who had died of pneumonia a couple of months before, who he never would have let this happen to. He said, I'm the chief operating officer. I gotta watch this stuff. You gotta back off. You gotta, if you're going down to the ICU, you gotta wait till they have their tracheostomies. Would you think I was lying if I said that happened to me? So I go down to the ICU, and I say to the chief of the ICU, who's still there, whose name is she's a lovely person. You like her. She's not this. She's a dynamo. She's amazing. She doesn't screw with anybody. I said, I just got screamed at because the tracheostomies are off this month. She goes, yeah, I know. You have to cool it. And what she was saying to me was, you can't bring people up to hospice until they've had their tracheostomies because we're losing money. And I said, okay, gotcha. She said, but it's wrong. I said, yeah, it's wrong. I said, I'm Jewish, so I'm not going to heaven either way. But you're going to have to explain to St. Peter when you get up there why we're doing this. Okay, so this is DRG. I can't read it.
Excuse me, why would you take somebody into palliative care if they could be helped or saved with tracheostomy?
I'm going to talk to you about that. Will you hold on that question?
Yes.
So this is DRG 207. This is mechanical ventilation for 96 or more hours. 96 hours is 5 days. The reason that's the cutoff is because that's the moment at which a tracheostomy becomes medically indicated, because now the tube is going to cause scarring. Okay? But let's take away the tracheostomy and let's take away the feeding tube. By the way, here's a guy who's orally intubated. I happen to think that this photo is fake, because I've never seen somebody look quite so relaxed with a tube in their trachea. It's like they're just kind of chatting. The other thing is he doesn't have a nasogastric tube, which you always, so if you have that tube down your mouth, you can't eat. So usually they put a tube in your nose to feed you. So I think this is just like a fake. But that's basically what it looks like. The relative weight is 5.1055. The prospective payment is $68,879.70. The difference between that and DRG 003 is $169,488.45. Now, you're all hospital CFOs. How are you feeling about this? Like maybe you should get another job? Are you feeling good about this? What if in the course of a year, your palliative care guy steals 100 transfers? Are you happy? That's millions of dollars. Millions and millions of dollars. Yes?
What I'm missing is when someone's really ill enough that they would be dying, how does this trach and everything save their life? Because maybe someone was in a car accident.
We've had a great bunch of questions, including that when I'm getting there. Okay?
What do you mean by steals? Do you mean like...
I stopped 100 tracheostomies from happening, and I've done it because I go down to the ICU and I go, you can give your dad a tracheostomy or you can not give him a tracheostomy and he will be dead by the day after tomorrow either way. I don't say it like that. Okay? But I say death is inevitable. Death is inevitable. So you decide. We're going to get to this. Is this a conspiracy? I have very, very mixed feelings about this. Okay? Would you rather have a kidney infection or a heart attack now or on June 20th, 1918? 100 years ago. The fee-for-service reimbursement system that happens in America followed the ability of doctors to do stuff that actually helps. It's funny, if you read a medical textbook from like 1875, it's basically just a natural history of somebody getting sick and dying from their illness. It's like, they start coughing, and then they start having fever, and then they start coughing more, and then they turn purple, and then they turn red, and then they turn orange, and then they turn blue, and then they die. It's like they couldn't do anything. If you were shot in the chest, BRG 003 would reimburse the hospital for saving your life. If you had a floppy mitral valve, the ECMO would save your life and make you feel better if your baby needed a new heart likewise. Okay? Selman Waxman discovered streptomycin in 1956. Prior to that, tuberculosis had killed more human beings than every war combined in all of history, by far. Just tuberculosis. You got tuberculosis consumption, you died. It's like HIV in the 80s. In 1958, that drug, was streptomycin, was given to a baby with tuberculosis, and here I am talking to you. Thank you, Selman Waxman. Selman Waxman was a Ukrainian soil biologist at Rutgers University. He got the Nobel Prize. You should just look up the picture because, like, Selman Waxman is like this tall, and like all these Swedish guys are like this tall. He's standing this. It's great. I have a friend who spent a couple years living in London, where they have National Health Service. And she said, I went to my primary doctor in London. I said, isn't it time for me to have my colonoscopy? Because it's a preventive measure, they can find colon cancer and save your life. Primary doctor says National Health Service doesn't pay for it after 6 months. So this is complicated stuff. There are no easy answers. So the questions that everybody, hold on a minute, the questions that everybody is asked is relevant. The problem is this. Prognosis is not part of this payment scheme. Okay. I could teach anybody in this room, and I am not exaggerating, I could teach you within 3 hours how to predict with 80% accuracy whether a patient in the ICU was going to survive the discharge or not. It's not hard. It just isn't. Okay. It is what we do. So if on day 5, a critically ill patient whose family is out of their minds with worry says to the ICU doctor, well, what can you do next? What can you do? And the ICU doctor says, well, a tracheostomy would be our next step medically speaking, because otherwise there's going to be scarring. And we'll have to put in a feeding tube too. You talked about people who go to long-term care settings. Like, there's long-term care settings, nursing homes are filled with people with not much in the way of any mental functioning, without tracheostomies, who are on ventilators and are getting fed by feeding tube, day after day, week after week, month after month, collecting bed sores, until finally they get an infection that we can't claw them back from. I've worked in nursing homes, I've seen it 10,000 times. So, if you get your tracheostomy on day 6, and your pulmonary infection spreads into your blood on day 8, and your kidneys stop working on day 9, and the cancer which brought you into the hospital to start with now has spread to your brain, and now it bleeds in your brain, which happens all the time, you are not going to survive. Period. This is not how I talk to other folk. But you are not going to survive. And when docs and nurses are sitting in the conference room, we don't spend a whole lot of time on this patient. We move on to the next one. The hospital still gets the $238,600.
Is that because they did the tracheotomy?
They did the tracheotomy and they did the feeding tube. Doesn't matter if the patient dies on day 7. Still get the payment. Prognosis is not part of the equation. How many times do you hear me say, these are good people? My friends who work in the ICU are really good people. I really like them. We get drunk together sometimes. Tracheostomies, in fact, are medically indicated after 5 days, and so are feeding tubes. Sometimes they're called PEGs. There's no obligation. There is no law that says prognosis must be discussed with the family. This is a really hard conversation. This is a conversation that I train people in. This is not something that you can just walk into, how to talk to families of critically ill and dying patients. Am I right, Henry? This is a hard conversation.
Isn't this what Atul Gawande is advocating?
What?
This conversation.
And you guys are going to be advocating for this when you're done with the talk tonight.
Sorry?
Yes, yes, you're going to be advocating for it too. When I started in 1993, there were 8 ICU beds. When I finished in 2016, there were 29. Why? Because that's where they make their money. Okay, the NICU, the neonatal intensive care unit, believe it or not, has an internationally known neonatal intensive care unit. They make a ton, ginormous is the word, right, of money. And the kids do pretty well. Medicine is a business. Hospitals provide services that reimburse the most. No sane chief financial officer would do things differently. They have negotiations with nurses who are demanding more money. They have poor kids to vaccinate. They have uninsured people to take care of. They have a big mortgage payment. At Bronx Lebanon, there was some poor guy who was undocumented who had kidney failure. And he couldn't be discharged because he couldn't get insurance, so he couldn't get dialysis because he was undocumented. So we kept him in the hospital so we could dialyze him in the hospital. He lived there for 2 years. And by the way, the whole thing that, the government doesn't pay for insurance for those people. Remember I talked about the disproportionate share payment? The disproportionate share payment is a pot of money in Albany that says, we'll pay you for the people you're not collecting. So they are getting insurance, but it's this ass-backwards system of, we won't insure them, but we'll pay for these egregiously high hospital costs.
Why wouldn't they transfer that to the patients who are paid nursing home?
Because they have no insurance, the nursing homes get paid. So eventually what happened was a nearby dialysis center said, just let them go, we'll dialyze them for free. For God's sake, just send them home. Because the people in the dialysis center are actually lovely people.
Love what?
Lovely people. Yeah.
Does that also mean that the hospital would want to run a bunch of tests to diagnose you with the worst possible thing so that then you would have a higher score?
It's not that bad.
Really?
It isn't that bad. But what the hospital has done is created a practice context in which all of this stuff can be done. If you have a friend who's an ICU doc, they're not going to go, yeah, I do stuff on people for money. They're not going to say that. But if Medicare, and they don't, but if Medicare came around and said, if the chance of a patient being discharged from the hospital alive in 30 days is less than 2%, and this is not rocket science. This is easy to predict. Just plug the numbers in. We're not paying $238,000. Half the ICU beds in the country will go away overnight because it's really expensive to run an ICU. And half the ICU docs will be driving Uber if they would deal. But Medicare won't do it, and I'll tell you why.
What happens if you ask for a prognosis? It may not be.
We're going to talk about it. We're going to talk about it. So what are the solutions? Any SpongeBob SquarePants fans? Remember when Plankton says, I'm going to rule the world? And SpongeBob says, good luck with that. Fee-for-service medicine is not going away. It's just not. Not now. We could have a relative wait for what's called a palliative extubation. Okay? So I spent a lot of my time in the ICU talking with really, really, really distraught families and gently bringing them around to the understanding that it didn't matter what we did to their loved one. If you bled into your brain and you're not making urine and your blood pressure is 50 because you have bacteria growing in your blood and you haven't made a drop of urine, doesn't matter what you do. It's about death tomorrow, at the end of the week, a week from now. And if those, and this is a really time-consuming process. It doesn't use up stuff, it uses up conversation. And I spend hours and hours and hours with people, and eventually they say, you know what, doc, my dad wouldn't have wanted this. So we want you to bring him up to your hospice unit and take out the food. Now, what if Medicare was to come around and say, this is a really legitimate way of managing patients. It's totally medically sound. It's reasonable, it's ethical. So we're going to pay for it. But we're not going to pay $230,000. We'll pay maybe $100,000 per patient. Remember, I'm negotiating with you as CFOs. Okay? If the average length of stay for somebody who gets those two procedures is 32 days, I can do this in 10. And I can do it in 10 days. Right? So let's go totally mercenary in business here. The throughput, you can do 3 times as many patients in the same amount of time and actually make more money. CFOs would be like, great, let's start doing that tomorrow. It costs less to do, and I have to tell you that, not the patients because they've died, but the families and the staff love this. The staff are like, why are we doing this to these people? And when I take them out to the hospital, like, thank you for taking them home. And the families, we do satisfaction surveys on them later, their relatives have all died, and they give us 100% satisfaction scores. And I'm always saying to residents, isn't the irony that you guys are working in the ICU, breaking your humps to save people's lives, and people are running screaming off to patient relations and complaining and suing you, and all my patients are dead and all my families are happy? What's that about? Okay, so do you think this will happen? I have to make this work. Give me a second. Hold on, I want you to watch this. Wait, watch. This is the odds of that happening. I had fun finding this. Who remembers her? Did I hear
Yeah.
I'm sure she's a lovely person. Former half-term Governor Sarah Palin on August 7, 2009 said, government health care will not reduce the cost. This was when Obamacare was happening. It will not reduce the cost, it will simply refuse to pay the cost. And who will suffer the most when they ration care? The sick, the elderly, and the disabled, of course. The America I know and love is not one in which my parents or my baby with Down syndrome will have to stand in front of Obama's, quote, death panel, so as bureaucrats can decide, based on a subjective judgment of their level of productivity in society, whether they are worthy of health care. Such a system is downright. I read an article the other day that said that the single phrase death panels is probably what Sarah Palin will be remembered. What this really should have said is, the system that exists now processes dying people through the hospital to generate revenues. Blatantly, it's about money. It's not about government not paying, it's about government paying. And Obamacare, by the way, which is now in force, did not change any of this. And one of the biggest criticisms of thinking progressive people about Obamacare wasn't that it was a good idea to insure everybody, it's that we had to change the way healthcare was reimbursed. We had to stop doing fee-for-service medicine, which is what Obamacare still is. This is where you guys come in. I have despaired of the healthcare system changing, and I think that what needs to happen is that patients and families need to start demanding that they be managed. And this starts to get to what I said at the very beginning about just getting to the point that you were talking about. Just getting to the point of having a spiritual end of life means you got to get through this first. You got to make sure you don't get snared by this. Okay? And I get calls from people all the time who they have no freaking idea of what's going on. And these are like educated people with great jobs. They're like, my father's in the hospital. They're talking about sending him to a nursing home. People have no idea what the forces are. I even talked about nursing homes. It's a whole other 2 hours about how they get home. We did this already.
Well, who gets reimbursement from hospital?
The hospice company.
Hospice company.
Yeah, so Connecticut Hospice, which is my employer, gets paid by Uncle Sam to provide hospice care through the Medicare hospice benefit.
So what is the hospital for?
I don't understand your question.
Well, if they have hospice in a hospital, and they do that.
Can they have hospice in a hospital? Okay. So, do you want to hear the most god-awful, mercenary, disgusting, money-driven idea you've ever heard? Here is the ideal patient for a hospital CFO. Okay? 5 days on a ventilator, tracheostomy, feeding tube. Immediate discharge, so you could actually be discharged in your hospital bed. You're still in your hospital bed, but you get discharged from your hospital stay. So now you get the $238,000 payment, right? And you immediately get enrolled in the hospital's hospice program, right? And that program has a per diem reimbursement of $850 a day. Okay? So that's just a suitcase with $850 a day waiting for you to come pick it up. Okay? Now, if that patient was going to be in the hospital for 20 days, okay, but you transformed that stay into 10 with DRG 003 and 5 in the hospice program, you've now generated 5 days at $850 a day. Okay? If at the end of those 15 days the good Dr. Sacco comes and pulls a plug on you, okay, you've opened up the bed for the next sucker in the ER. This is a perfect patient. Hospice actually fits into this model. Hate to say it, but it does. Okay, so palliative care, yes.
Would it be possible for the physicians to change some of the guidelines for ECMO and some of these high RW diagnoses?
The short answer is no. No.
Okay.
We're too busy trying to get through rounds.
Well, my complete question was, would it be possible for them, or let's say, another body, to kind of change that so that it's not as easy for the physicians to, let's say, okay, well, we're going to go through this more expensive route rather than going through the cheaper route, like in terms of the patients.
I understand this. My sense is that the only way this is going to be paid is if it becomes a national disgrace, and everybody knows it's happening and takes it. And right now, apparently, there's bigger national disgraces that everybody's happy with. So, okay. I told you about this. Now, so this sort of gets into what palliative care is, and I have a half an hour to go, but some of this sort of incorporates some of the training I do with residents in medical schools. So I've told you this. It serves seriously ill people and their family. It is truly multidisciplinary. It involves social work, it involves nursing, it is collaborative and not hierarchical. It involves the chaplaincy, etc. Patient and family centered is one of those phrases that people love to say, but nobody really knows what it means. We're patient and family centered. It's like, I have an image of, I've been saying lately that you can't see a pharmaceutical commercial these days without seeing an attractive older woman doing yoga. And the name of the drug. She had rheumatoid arthritis, but now she's doing yoga. It is inclusive of conventional medical care, and I will talk more about that. It is really, the focus is on counseling and promoting choice, including the completion of legally binding advance directives, and my teaser for our next session is it's all going to be about advance directives and how to legally ensure that you get the care you want with paperwork. And like I said, I love morphine. We're expert at symptom management. I said that the job of going down to the ICU and sitting with a distraught family who have a critically ill relative, and they really don't know what's going on, that job of sitting with them and helping them get their heads around what's actually going on, so that they can understand what's happening, so that they can understand what their treatment choices are, and so that they can make decisions that comport with their wishes and beliefs, is what palliative care is. That and morphine. And some paperwork. Yes?
Can you explain briefly how morphine helps make someone die, or is it really just that
It doesn't make people die.
It doesn't.
So that's a myth. That's apocryphal. So if you take 100 people on ventilators, and you give half of them morphine, and the other half you don't give morphine, and you take them all off ventilators, they've done this study. The ones who got the morphine live longer. So forget about morphine killing people. It's just a myth.
Do they die with an overdose of morphine?
No, they die from their disease. They die from their disease.
It doesn't slow the respiration down.
It's all nonsense. I'm telling you, I use morphine all the time. I've never killed anybody.
And they need it.
I've never killed anybody, but I've never killed anybody.
You're giving it to them because they're in extreme pain.
You give it to people to relieve distress, and it works like a charm. I'll tell you about an example of palliative care that happened to me within the last year or so. So we had a patient in our home care program at hospice. So we have a regular home care program that's not hospice, like a visiting nurse service, right? And this is a woman who lived in Guilford, Connecticut, which is about 15 minutes east of us in Branford, a lovely little seaside town. She lived right across the street from the water, beautiful setting. She had a big golden retriever, and she had gastric cancer. And she was really distraught. She was really anxious. I would be too if I had gastric cancer. And she'd been to the boy wonder gastric surgeon, who was the best known guy in the entire universe, who had the best outcomes, and she'd gone to see him, and she didn't understand a word he said. And so she was in our program, and she had a lot of trouble with eating. Unsurprisingly, she had a lot of pain. I went to see her at home. Now, this is not about me, but this is about the specialty. I went to see her at home, little dab of morphine, feeling better, calm her down, start to have a conversation. You know, doc, I don't know what to do. I just don't know what to do. I don't understand what's going on. I don't know what to do. I'm so anxious. So I said, well, you want me to call Boy Wonder at Presbyterian? And call. Talk to him. She said, yeah, would you? So one of the best things about being a doctor is other doctors return your call. Remember what you were saying, Henry? It's like they have no choice. Like, just pick up the damn phone, right? Or I'm calling the department chair, kind of thing. So they return it. So I get this guy on the phone, and he's lovely. He's like young and energetic, and he's got this published and everything else. And he gives me the short down and dirty version, doctor to doctor, and I called her back, and I translated it for her into English. But it's not really about her understanding. It becomes about relationship. It becomes about the fact that I went to her house and I did what I told her I was going to do. And so she started to relate to me as Joe. And she said to me, well, what would you do? And I said, are you asking me as a doctor or are you asking me as Joe? I'm asking you as Joe. I said, I get the surgery. I really like living. If there's a chance of cure, I'm going to go for the chance of cure. And I said, and by the way, we're going to be there with you every step of the way. I'm going to be prescribed, my prescription pad is going to be smoking from all the morphine. Okay. And the social worker is going to be calling you, and the nurse is going to be coming by, and we are going to hold your hand through this process. That was almost 2 years ago. She's now back to her job as a real estate agent. She has been discharged from our home care program, and she still emails me. Hey, how you doing? I thought you would enjoy this video lesson. So it's not always about dying, it's just about serious illness. Now, if her disease comes back, which it may, we'll be there for her. And if it gets to the point where hospice is appropriate and it's what she wants, we'll be there for her. My job in the ICU is not to talk people out of tracheostomies and feeding tubes. My job is to make sure they understand the consequences of those decisions. About 5 years ago, I had a call one day from a young woman when I was still at I said, Dr. Sacco, it's the second anniversary of my father's death, and I was thinking about you, and I just wanted to say thank you for all the support you did for us. You really made a difference. This is not, doctors are grandiose, but it's the specialty. Okay? And I said, oh, ma'am, I'm so pleased. I'm so glad you felt that way. My condolences. I hope you're moving along with life. And then when I hung up the phone, I got to be honest, I don't remember all my thousands of patients. And so I looked her up. And her dad had died in the ICU after undergoing a resuscitation protocol 5 times. So this was the epitome of futile ICU care. But what had made the difference to her was the support in the relationship. It was the support in the relationship. What she remembered, and I think anybody who's gone through the experience of having a very sick loved one, what you remember 5 years and 7 years and 10 years later isn't your loved one in sickness. It's the relationships that you formed when that person was sick. So I don't have an agenda. If you want to die in the ICU, it's okay with me so long as you know what you're choosing. This is really what it is. That's really what.
So what's the time trigger on palliative care?
The time trigger is when you as the patient say, you better send the damn palliative care specialist in because I'm getting freaking sick and tired of this. Because so palliative care is almost always the consultative service in the hospital. And consultations are driven by the attending. So regardless of what you think about how medicine is practiced, the truth of the matter is that the attending doc in the hospital who's in charge of the case. So if you get admitted from the emergency room, you don't have a private doc, you're going to be assigned an attending doc. That person is in charge of calling consultations. And typically and that person would be in charge of calling palliative care. And typically what happens is a lot of the attendings are like, no, you're not ready for palliative care because they don't understand what the specialty is. So more and more and more in hospitals, I'm having people say, so why did you call palliative care? They're like, well, the patient asked for it. And that's what I want you guys to really go out and work on, is grassroots advocacy.
I guess my question is, because that's absolutely true, when you talk palliative care, people automatically think hospice, and they think, you said palliative care, and they think, now I'm dying, this is it, I'm going. How do you have that conversation to swing it to, palliative care is palliative care, and hospice is hospice?
Can you repeat that? I'm not sure I understood.
So, in other words, I've run into the situation when you try and talk to people about palliative care as opposed to hospice care, people automatically think that palliative care, they lump it together with hospice.
So we need a new title for our profession. If you can think of one. We've been starting to call it supportive care.
Okay.
But it's true. Everybody's like, no, not palliative care. I'm not there yet.
Right.
I'm still going to get treated. No. And then after we're done with the conversation, she's like, oh, that was nice. Thank you. All right, so just a couple of points, and please, other folks who have experience with this, please feel free to jump in. But this is a little bit about some of the techniques of palliative care, which isn't necessarily relevant to tonight. But I think it's interesting if you guys are interested in hearing a little bit more about how it's actually done. It's the same system.
Who refused to talk with his primary care doctor, and as a result, he died.
He refused to talk to his primary care doctor? So, you can bring a horse to water and you can put a gun to its head, but you can't make a train.
So then my question is, if you've got a hospitalist like that and you say, I want somebody a specialist in palliative care, what leverage do you have to make sure that it happens?
Patient relations. I asked for palliative care and they didn't come back yet. I'm starting to get angry. I'm going to give you guys really sucky reviews on TripAdvisor. Send palliative care. No. Patient relations are wonderful. All right, so just a little bit of a demonstration. I kind of need a volunteer for this. You want to volunteer? Would you come and sit here for me? And I need something I can pretend is a chart. Sure. So I'm going to be your doctor in the hospital, and you're going to be in a bed, and I'm going to pretend that this is your chart.
Okay.
So I'm going to be holding your chart, and I'm going to come in like this, and I say, hi, my name's Dr. Sacco, and I'm here to talk to you about your medical condition. Tell everybody in the room how you feel in this moment, in this room right now with me.
I feel better.
Thank you. Okay, let's do some play acting. Pretend that I'm like the regular allopathic doctor, and you're in the hospital, and you're really scared, and I've just marched into your room, and I'm standing over you like this. You're supposed to go with this. And I'm holding your chart like this. How do you feel?
I think you need to pick someone else to do this because I'm so weird.
Just say I feel a little anxious.
Okay,
I feel a little nervous.
I feel anxious.
Okay, thank you. No, you can stay there though. Hi, Coupe. My name's Dr. Sacco, and I'm here to talk to you about your medical condition. How do you feel now?
I feel better.
Don't you feel even better than you did?
I do.
So just how we present ourselves to people with our body language starts to form a relationship. I'm not looming over you. I'm not in your space. I've separated myself back from you. The other thing is I'm not standing and I'm not holding your chart. The message of I'm standing over you and holding your chart is, I was on my way somewhere else, but thought I would drop in and say hello to you, but really don't use up much of my time because I got to get out of here. So right now I'm intentionally crossed my legs and folded my hands and sat down to tell you I'm actually here to talk to you. Thank you for your help.
That was it?
That's it. You did a great job.
I don't know about that, but thank you.
What's your name? Vibhuti, I'm here to tell you about your medical condition. Versus, Vibhuti, would you like me to tell you about your medical condition?
Yes, please.
Which would you rather hear? I'm here to tell you about your medical condition, or would you like me to tell you about your medical condition? Which would you rather hear of those two statements? The point being that asking permission is another unconscious means of forming a relationship with a patient, because you are removing it's not I'm the doctor and I'm going to impose my knowledge on you, it's we're in a partnership. Would you like me to tell you about this? Now, you might think that I'm gaming the patients, but I'm not. I actually believe this stuff. I want to form relationships with people. And these are some of the time-tested techniques, right? Validation. Let's go back to the very beginning. Your cousin is sobbing on the phone. I don't know what to do. I don't know what to do. I don't know what to do. Okay. I know what everybody in this room would say next. And I'm going to whisper it in someone's ear. Just so, like, we're on a game show and I'm a magician. Before anybody says it. Can I whisper it in your ear?
My name?
No, can I whisper what everybody would say next?
Sure.
Don't say anything. My mom has breast cancer, and I just found out today, and I don't know what to do, and you're a doctor, and I don't know what to do. I don't know what to do. She starts sobbing. What do you say next?
I think, calm down.
No, that's not what you say. What do you say? Just what I was saying. No, that's not what you say. What do you say? I'm going to tell you all what you say next, and when I tell you what you say next, I'm sorry, you're going to go, of course that's what I say. You're going to say, I'm so sorry to hear. So, wow, it must be such a shock. And then the next thing you're going to say is, whatever I can do to help her. That's why she called. When was the last time you were in a medical setting with a serious problem, if anybody in here has had a serious problem, and had the doctor say, I'm sorry, I just must be with you. Never. Okay. Validation. I say to families all the time, I've been through the experience of having a loved one get sick and die. And I know how lousy it is and how awful it is and how you wake up with it in the morning and you go to sleep with it at night and it consumes your day and it causes anxiety and you don't know what to do. And I just want you to know that my thoughts are with you. I don't say my prayers are with you because I don't pray. But I've been given permission by a priest. So it's the thought that counts. Validation. People do this, literally. Henry, you can tell me if this is right. People do this. They're like this. They're like braced as though it's a big wave that's going to come and hit them. You say, I'm really sorry to hear that. And I'll do what I can to help you out. And what happens is this. And the tissues. Always have tissues available. The bottom one, communication on an ongoing basis, it doesn't stop with one interaction. The woman in Guilford, who by the way was in an article that was written in the New Haven Register about us, this was a process that went on and on, and it was multiple phone calls and visits. So it doesn't happen that easily. It takes time. I love this cartoon, because this really is like when I saw this cartoon, it was like, wow, they recognize palliative care. Can you read it?
Yeah.
Doc's saying there's no easy way I can tell you this, so I'm sending you to someone who can. Because he doesn't know how to talk. I'm sure he's a lovely guy. I get this all the time. Do you want me to tell you what's going on? Yes! Nobody's telling me what's going on, please. And then I say, is it okay if I'm very direct with you? Can I be very clear? Can I talk with you honestly? Doc, please. So then I have a really difficult conversation about a really difficult condition, and at the end, what do people say? Well, thank you. I know now. Now I can decide. My friends in the ICU, as lovely as they are, they're so freaking burned out. It's like they go, they do the work, they go home. They don't derive any joy from their work anymore. So I do this with students and docs. And I've seen this. It was interesting because at the house staff, the residents there were entirely foreign medical graduates, and they were really smart, really well-educated people, and they had come often from very well-established practices where they were leaders in their field in their own country, but they couldn't get residencies in Presbyterian, so they wound up in the South Bronx. I went to the South Bronx in 1995 because I'm a Jewish liberal, and that's where I wanted to be, and I stayed there for a while. But I would see really well-intended, lovely, polite, terrific, smart residents saying this to people from the South Bronx who were not high school graduates. Now, in order to survive in the South Bronx, you have to be pretty freaking smart to survive. That doesn't mean that you graduated from high school, but it means that you're intelligent. So there's not a gap of intelligence, it's a gap of language. Does anybody in this room know what this means? Some of you do.
And how would you say it?
This is my favorite all-time Far Side cartoon. Captures all of it. So the owner is saying to his dog, okay, Ginger, I've had it. You stay out of the garbage. Understand, Ginger? Stay out of the garbage or else. Now, Ginger doesn't speak English. But it's the same thing about body language, right? It's the, okay, Ginger. It's the body language, it's the tone. Ginger knows she's in trouble, but she doesn't know it's about the garbage. What the dog hears is, blah, 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 Ginger. Blah, blah, blah. It's like, what did I do? But they say there's no good in beating up your dog, because the dog's like, what are you doing? They don't associate it with something that pissed you off. Use positive reinforcement. I got busted for this. I was in and I was talking to a family member in the ICU conference room like this, and I got busted. I got busted for being racist, and I got busted for being classist. Because I started dumbing it down for the African-American gentleman across the table from me, assuming that he didn't know diddly squat about medicine. Because I'm a white guy and I have racist assumptions that I always have to be conscious of. And he said to me, Dr. Sacco, I'm the chair of anesthesia at George Washington University Medical School, and I meet with President Obama twice a month to discuss bioterrorism, and also I'm head of the medical board. And I just looked around, and he just had me. And I just said, you got me. I said, you got me. I'm not gonna backpedal or anything. And he said, and he actually sort of saved me. He said, so you know what, I think I learned a little bit about how I should be talking. So we're good. So now I go, I'm going to talk to you in plain English, is that okay? Okay. If you're a doctor or a nurse or something, just let me know and I'll talk to you in medicine. I don't want to get caught for that again. I don't know if I want to get into this. It's more sort of esoteric, but it's sort of talking about resuscitation. I don't know if I want to get into the...
No, well, you have time. You're not on the clock. If anyone has to leave, that's okay, but you're not.
So, you know, those of you who work in hospitals know that, like, the decision about resuscitation is always posed to patients. Okay? It's like, what do you want us to do if your heart stops or your breathing stops, right? And, you know, and I have to say that I have actually seen residents who are lovely. Aren't they? They are. They're really sincere. Sometimes I feel bad for them. And I go, you poor devil. You need to go drive Uber. If your heart stops or you stop breathing, do you want us to bring you back? Think about it. Like, doesn't it give you this sort of image of, like, blackness? This is the Hollywood version. And then there's a little pinhole, like, it starts to get bigger, bigger, and you start to see colors. And you get bigger and bigger, and there's butterflies close by. And you burst out into a beautiful garden. Got brought back. That's really what I picture. You know, you guys are probably a little bit cynical about this, but if anybody ever says this to me, I'm like, yeah, bring me back. I want to get brought back. Because the implication is, do you want us to bring you back to health?
Or maybe not. There are many people who had near-death experiences and they say, it was so beautiful, I didn't want to come back.
So that's your guys' next talk that I will attend and listen to. You can read this. So remember, I've asked permission. I can be this blunt because I have asked permission. I can be clear and speak in English. I give the example of my mother. Okay? My mother at the age of 79, had a heart attack. Everyone was always saying a massive heart attack. She's had a regular heart attack. She went to Lenox Hill. She proved to be having a heart attack. She got admitted to the CCU, and her heart stopped. Now, in that moment, my mother was a basically healthy 79-year-old woman living in a studio on East 86th Street. Liked a martini, liked to go to the movies, liked to hang out with her friends. She had perfectly decent kidneys, lungs, brain. She was a difficult person, but no dementia. Okay? No major medical problems, no high blood pressure, no diabetes. She just had a heart attack. So in that moment, it was like, you guys don't, I mean, some of you guys live in houses, but you know, like when the power goes out in your house, everything's good. The fridge is good, the microwave is good, the washer dryer is good. Everything's good, the TV is good. Everything's good, you have to restore the power. So when my mom died, they came and did advanced cardiac life support, which is CPR and all the other jazz that they do. They responded within 30 seconds of her heart stopping, and they had resuscitated her. They got a pulse back within 5 minutes. I told the CCU attending it, my mother's not sitting up and talking in 72 hours on pulling the plug. Because I know what the data shows. He said, I think you're being emotional. I said, you're right, I'm being emotional. I really am. And if she's not off the ventilator and sitting up and talking in 72 hours, you're pulling the plug. 72 hours later, she was sitting up in bed, cursing out the nurses. Because they'd broken a couple of ribs. And I said, they broke a couple of your ribs. She said, well, why did they do that? I said, well, they were saving your life. She said, well, why did you let them do that? She was difficult. She lived 5 more years. 5 more years of a nice life. I mean, she was difficult. So I tell people this example, this personal example, so they can understand the difference between, it's not about how old you are, it's not about how frail you are, or anything. It's about what's wrong with you. If your kidneys have shut down, if your body has been overwhelmed by a malignancy that's resistant to treatment, if you're bleeding, if you have a generalized infection, it doesn't matter if you restore a heartbeat, none of those organs are going to start working. If you restore power to the house and the house is burned down. And so people go, well, I don't want that. And we do not resuscitate water. Which was almost entirely, the patient population was almost entirely African American, black people from other parts of the world, the Caribbean and Africa, and Latino people from all over the world. The highest rates of do not resuscitate orders in underserved minority populations who suffer from health disparity, the highest rates in literature are about 20% of signing DNR. And the reason for that is because people are reluctant to forego a medical intervention if they've had shit for medical care their whole lives. Sorry, I was worried. So that makes sense. I'm a white guy. At Bronx Lebanon, my rate of DNR consents in our African American Latino population is 70%. Why? Because I explained it. And I formed a relationship with our patients. I forget this all the time. This is how to deliver bad news in a way that is useful for people and that leaves them feeling empowered about making decisions. So I took this picture in the ICU. You can't see it, but this guy is orally intubated. I used to say, I don't think that there's a computer program powerful enough to figure out all the medication interactions that are going on with all those IV pumps. Now, I'm going to say something that maybe you guys aren't going to like, but I'm not a big fan of death. I mean, when my time comes, hopefully, I'll be hanging out with you guys, and you'll have taught me how to live fully while I'm dying. But right now, I'm scared shit of death. I just am. And I check my calendar. I don't have time for it. Like I said, my job is not to talk people out of this. My job is to help people understand what the consequences of this is. And if they choose this with their eyes open, I go home feeling good. And then maybe 2 years later, I get a call thanking me for the support. So that's what palliative care is. So this woman gave me permission to use her photograph. Her name is Frances Figueroa. And she died of cholangiocarcinoma in Calvary about 10 years ago. She was about 35. She had 3 young children, a huge family, huge adoring family. You can see the jaundice in her skin and her eyes. We did everything for her. The oncologists bent their silly backsides over backwards trying to save her life. We did everything right. We did the palliative care thing, the hospice thing. She went to Calvary. She died without pain. She was surrounded by her family. She did not get undignified care. But you can't call it a good death. You can't. I mean, she relates better to the camera than I can relate to a person. Look at her. So I just add this as a caveat. And, you know, from a spiritual perspective, there's a whole different outlook. But I'm being the allopath that I am. I just couldn't get my head around this. I had a guy in hospice who was 26, who was a Harvard law student. And he was actually up by Presbyterian, and he'd come into the city for summer internship jobs. He got hit by a motorcycle and had traumatic brain injury. And I got to know his family. He came into hospice because 2 years later, they decided to stop feeding him. His mom and dad decided to stop feeding him. He was tube fed. And they had pictures of him all over the wall. I'm like, oh my God, I would have loved this guy. He like traveled the world, and he had a great girlfriend, and his family loved him, and he hung out with his sisters, and he had great friends, and he was generous. It took him 6 weeks to die. So it sort of brings me back to nobody really wants to meet us to start with. Did you ever read the Superman where there's no crime and no war, and he has nothing to do? He's kind of dejected. That's like where I want to be. But maybe you guys can help me, because that's not what's going to happen. This is Felix Navarro. So Felix worked for Con Edison, and he was down at ground zero immediately after 9/11, fixing the electricity. And then he was in the sort of the medical follow-up of everybody. And so he got screened and screened and screened for diseases, and they found that he had lung cancer. So this was in like 2007. And so I got called to come and talk to him because he was in a lot of distress, a lot of anxiety, a lot of fear, a lot of pain. I spent a lot of time with him, a lot of morphine, and he elected to get surgery. And so the cardiothoracic surgeon, who actually never met him, operated on him, took the malignancy out, and saved his life. He's alive. He lives in Orlando now. But look at him. Look at the smile. He still Facebook messages me. It was my birthday the other day. He's like, Dr. Sacco, the best doctor in the world, happy birthday. It's like 15 years later. And I keep saying to him, Felix, it was the surgeon who saved your life. He's like, no. I held his hand. He started to have a little issue with opioids for pain, but I held his hand and got him through this for like 2 years after his surgery. And he's great now. Did someone have a question? I'm not going to tell you what the CAT scan shows because I made it up. You feeling a little more in control of what happens next? You're not? I've totally failed in 2 hours. Really what I would say to everybody in the room is understand what the forces are that you don't know about that are pushing you in a certain way. And being pushed in that direction may be where you want to go. I mean, that may be what you want and that may benefit you. But understand it, and understand that you have choices in terms of being put more in control of what happens to you.
Oh, I didn't mean that. I meant in terms of getting the CT scan back.
Oh, but now you're like, once I got the results, I'm going to be able to decide what I want to do because that weird dude gave that talk. Oh, we're August 1, right? Or did we change it?
Are there any that you take 2 questions?
Yes.
A couple questions. Does anyone have a burning question?
Yeah, I have a question. My mother and I are working on healthcare processes directives right now with care. So
You don't know the lawyer, for God's sake.
so that means that if I come on the source, then I have to update whatever the lawyer does, I have to update everything.
I will walk you through all those documents. And the nice thing about those documents is that they're legal. So people can't undo what you put in the documents. And I've been in situations literally like hiding behind a living will and having a family scream at me, demand I do something, but I couldn't because it was on the living will.
What we talked about, which I think is important, is you have a patient and the doctors are offering a treatment that might have a 10 or 15 or 20% possibility, but with side effects. And they want their end of their life to be more about living than dying. So without that treatment, it might be more about living. How do you deal with that situation when you're?
So I think that there's no absolutes, right? There's no right or wrong here. You can't know what the future is, right? You can't know if you might have hit that 15% chance of a cure. You can't know. All you can do is hopefully be provided with information that's accessible and understandable to you, which is what palliative care is, and then use that information and your own wishes and desires and beliefs to make a decision. But you can't there's no guarantee you made the right decision. You just make a decision and go with it, or maybe change your mind. I've had people come into hospice, mental illness and cancer are a really bad combination, right? Because people who are mentally ill often can't cope with what they have to go through to deal with cancer. And I've had people with cancer who are mentally ill who are totally curable come into hospice because they couldn't cope with it. And I've had arguments with them, but leave hospice now and go get surgery. No, doc, I'm not doing it. Why? I don't want the anxiety. Like, that's crazy. Deal with the anxiety. You're going to be cured. No, doc. So, it's your choice. I mean, that's the whole point of this. Is you make it your choice, not the default position of a system that will process you through. And they may process you through to being better, but they're going to process you through unless you do something about it if that's not what you want. And please, again, let me just advocate for not throwing the baby out with the bathwater. Just amazing stuff is available to all of us. When you think about the heart surgery thing, when you think about that, it's incredible. I mean, we've gone in 100 years from like wooden sailing ships to, stopping people's hearts and fiddling around with them and then putting them back together. It's incredible. So, any other questions?
I just wanted to make a comment about Barbara's question, because I think one of the things we don't do is we don't ask enough questions of our doctors. We really have to keep pushing for answers to our questions. And we have to understand fully what the ramifications are of the decisions we're making and think through, so if I take this treatment, if I decide to do this, and you're telling me there's a 10 to 15% chance that it's going to be helpful or effective, what does that mean actually?
Exactly.
And if I do decide to do it, is there a way that I will know at some point as the treatment is going on that maybe it's not doing enough to counterbalance whatever side effects I'm experiencing? But we don't ask fully. We don't, doctors have this sort of aura of authority, and we don't penetrate it. We don't ask fully for what we need to know. That's the advocacy that I think you're trying to encourage people to have. We have to be really good advocates for ourselves in the healthcare system.
And on that note, Henry, you said one of your patients was actively dying and they were dragging him off to a CAT scan. So who's the person that's going to come in and say, but he's got 2 days left. Don't drag him to a CAT scan, where he's going to be in pain and uncomfortable and not peaceful or at home or whatever.
Well, you guys are going to advocate for more palliative care nationwide.
Yes. Thanks, Henry. So stay tuned and join us for a lot more amazing classes and workshops. And thank you so much. This was awesome.